Bulimia nervosa represents one of the most misunderstood yet prevalent eating disorders affecting people worldwide. Unlike some eating disorders that cause dramatic visible weight changes, bulimia often remains hidden, with those affected maintaining what appears to be a normal weight while suffering intensely in private. This serious mental health condition is characterized by recurring episodes of binge eating, consuming unusually large amounts of food in a discrete period, followed by compensatory behaviors intended to prevent weight gain. These compensatory behaviors might include self-induced vomiting, misuse of laxatives or diuretics, fasting, or excessive exercise. Today, we'll explore bulimia nervosa in depth, examining its defining characteristics, underlying causes, warning signs, health consequences, treatment approaches, and paths to recovery. By understanding this condition more thoroughly, we can better support those affected and contribute to earlier intervention and more effective treatment. Defining bulimia nervosa. Bulimia nervosa is defined by a distinct pattern of behaviors and psychological experiences. The first key feature is recurrent episodes of binge eating. A binge involves consuming an amount of food that is definitely larger than what most people would eat during a similar time period under similar circumstances, accompanied by a sense of lack of control, feeling that one cannot stop eating or control what or how much one is eating. These binges often occur rapidly, sometimes in secret, and typically continue until the person feels uncomfortably full. The second defining feature is recurrent inappropriate compensatory behaviors to prevent weight gain. The most common is self-induced vomiting, occurring in 80 to 90% of cases. Other methods include laxative or diuretic misuse, fasting for extended periods, or excessive exercise. These behaviors must occur, on average, at least once a week for 3 months to meet diagnostic criteria. A third critical element is that self-evaluation is unduly influenced by body shape and weight. People with bulimia place excessive importance on their physical appearance in defining their self-worth. Unlike anorexia nervosa, individuals with bulimia typically maintain a weight that is normal or slightly above normal for their age and height, making the disorder less immediately obvious to others. Bulimia is classified into 2 subtypes: purging type, where the person regularly engages in self-induced vomiting or misuse of laxatives, diuretics, or enemas, and non-purging type, where the person uses other inappropriate compensatory behaviors such as fasting or excessive exercise, but does not regularly engage in purging. The purging type is more common and associated with more medical complications. Causes and risk factors. Bulimia nervosa, like other eating disorders, develops from a complex interplay of genetic, biological, psychological, and social factors. No single cause has been identified, but rather a constellation of vulnerabilities that, together, increase risk. Family and twin studies suggest a genetic component to bulimia, with first-degree relatives having significantly higher rates of eating disorders. Neurobiological factors appear to play a role as well, with research pointing to dysregulation in brain systems governing reward, impulse control, and emotional regulation. Psychological factors strongly associated with bulimia include low self-esteem, body dissatisfaction, perfectionism, and difficulty managing emotions. Many people with bulimia describe using binge eating as a way to cope with negative emotions, with the behavior providing temporary relief or distraction from psychological distress. Issues with impulse control and difficulty tolerating negative emotional states are common. Histories of trauma, particularly childhood trauma and sexual abuse, appear more frequently in those with bulimia compared to the general population. Sociocultural influences contribute significantly to bulimia's development. Western culture's thin ideal creates immense pressure to achieve an often unattainable body type. Diet culture promotes rigid thinking about good and bad foods, creating an environment where normal eating becomes increasingly difficult. Certain environments intensify these pressures. Competitive sports and activities emphasizing appearance or weight classes show higher rates of bulimia among participants. The onset of bulimia typically occurs during adolescence or early adulthood, often following a period of dieting. Many individuals report that their binge-purge cycle began after a strict diet created physical hunger and psychological deprivation, leading to a binge that was then followed by compensatory behaviors to prevent weight gain. This establishes a destructive cycle that becomes increasingly difficult to break without intervention. Warning signs and symptoms. Recognizing bulimia nervosa can be challenging because those affected often go to great lengths to hide their behaviors and typically maintain a weight within the normal range. However, several warning signs may indicate the presence of this disorder. Physical signs include fluctuations in weight, rather than the steady weight loss seen in anorexia, swelling of the cheeks or jaw area due to enlarged salivary glands, calluses, or scarring on the knuckles, Russell's sign, from self-induced vomiting, dental problems including enamel erosion and increased sensitivity, and chronic sore throat or hoarseness. Behavioral signs are often more noticeable to those close to the individual. These include evidence of binge eating, such as disappearance of large amounts of food in short periods or finding wrappers and containers indicating consumption of large amounts of food. Signs of purging behaviors include frequent trips to the bathroom after meals, sounds or smells of vomiting, or packages of laxatives or diuretics. Other behaviors include excessive exercise regimens that don't change despite injury or exhaustion, withdrawal from usual friends and activities, and extreme concern with body weight and shape. Psychological warning signs include preoccupation with weight, food, calories, and dieting, extreme body dissatisfaction, and expressions of guilt or shame about eating. Many individuals with bulimia experience intense mood swings, irritability, and depression. The person may develop rigid thinking around food as either good or bad and express feelings of being out of control around food. Social withdrawal is common, especially from activities involving food. Many report feeling trapped in the binge-purge cycle despite wanting to stop. The pattern of behaviors in bulimia often follows a predictable cycle: dietary restriction leading to extreme hunger, triggering a binge episode, followed by feelings of guilt and shame that prompt compensatory behaviors, which temporarily relieve distress but ultimately reinforce the cycle. Understanding this pattern is crucial for both recognition and treatment. Health consequences. Bulimia nervosa can have serious, sometimes life-threatening health consequences affecting multiple body systems. Unlike anorexia, where the primary physical dangers stem from malnutrition and starvation, the health risks in bulimia largely result from purging behaviors and the cycle of binging and purging. Electrolyte imbalances represent one of the most dangerous medical complications of bulimia. Frequent vomiting depletes the body of essential electrolytes, particularly potassium, sodium, and chloride. Low potassium, hypokalemia, can lead to cardiac arrhythmias, muscle weakness, and in severe cases, sudden cardiac arrest. Other cardiovascular effects include irregular heartbeat, weakened heart muscle, and low blood pressure. The strain of induced vomiting can cause small tears in the esophagus or even catastrophic rupture in rare cases. Gastrointestinal complications are common and include chronic inflammation of the esophagus, acid reflux, stomach rupture, a rare but life-threatening emergency, chronic irregular bowel movements, and rectal prolapse, particularly associated with laxative abuse. The frequent exposure to stomach acid from vomiting causes significant dental problems, including erosion of tooth enamel, particularly on the inside surfaces of front teeth, increased tooth sensitivity, and higher susceptibility to cavities. Salivary glands often become swollen and painful, causing a characteristic chipmunk cheek appearance. Endocrine and metabolic disturbances occur as the body adapts to the chaotic eating pattern. Menstrual irregularities are common in women with bulimia, though less frequent than in anorexia. The cycle of binging and purging disrupts normal hunger and fullness cues, making it increasingly difficult to recognize and respond appropriately to the body's natural signals. Psychological consequences include increased anxiety, depression, and substance abuse. The shame and secrecy surrounding bulimic behaviors often lead to social isolation and relationship difficulties. Many individuals report feeling trapped in a cycle they desperately want to escape, but find themselves unable to stop without professional help. The preoccupation with food, weight, and purging consumes enormous mental energy, affecting work or academic performance and overall quality of life. While the mortality rate for bulimia is lower than for anorexia, it remains significantly higher than that of the general population, with deaths resulting from medical complications or suicide. Early intervention is crucial to prevent these serious health consequences and begin the recovery process. Treatment approaches. Effective treatment for bulimia nervosa typically involves a comprehensive approach addressing both the behavioral symptoms and underlying psychological factors. Unlike anorexia, where hospitalization is often necessary, bulimia can frequently be treated on an outpatient basis unless medical complications are severe or other psychiatric conditions require more intensive care. Cognitive behavioral therapy, CBT, particularly enhanced CBT, CBD, specifically designed for eating disorders, is considered the gold standard psychological treatment for bulimia. This structured approach typically spans 20 sessions over 5 to 6 months and focuses on disrupting the binge-purge cycle, normalizing eating patterns, and challenging distorted thoughts about weight, shape, and self-worth. CBT helps individuals identify triggers for binge eating and develop alternative coping strategies for managing difficult emotions without turning to food. Interpersonal psychotherapy, IPT, represents another effective approach, focusing on resolving interpersonal problems that may contribute to the maintenance of bulimic symptoms. Dialectical behavior therapy, DBT, has shown promise, particularly for individuals who struggle with emotional regulation and impulsivity. Family-based treatment, while most established for anorexia, has been adapted for adolescents with bulimia with encouraging results. Nutritional counseling forms an essential component of treatment. Working with a registered dietitian helps establish regular, balanced eating patterns, typically 3 meals and 2 to 3 snacks daily. This regularity helps reduce the extreme hunger that often triggers binges. Rather than focusing on restriction, nutritional approaches emphasize adequacy and variety, working toward including previously forbidden foods in moderate amounts to reduce their psychological power. Medication can play a supportive role in bulimia treatment. Antidepressants, particularly selective serotonin reuptake inhibitors, SSRIs, like fluoxetine, Prozac, have demonstrated effectiveness in reducing binge purge episodes, even in individuals without co-occurring depression. Fluoxetine is currently the only medication specifically approved by the FDA for treating bulimia nervosa. Other medications may be prescribed to address co-occurring conditions like anxiety or depression. The level of care is determined by several factors, including medical stability, frequency and severity of symptoms, and previous treatment history. While outpatient treatment is most common, more intensive options include intensive outpatient programs, attending treatment several days per week while living at home, partial hospitalization programs, full-day treatment while returning home evenings, and residential treatment, 24-hour care in a non-hospital setting. Inpatient hospitalization may be necessary for medical complications requiring acute care. Treatment outcomes for bulimia are generally positive, with approximately 50 to 70% of patients achieving significant reduction in binge purge behaviors with evidence-based treatment. However, recovery often occurs gradually, with occasional slips or relapses during the process. Ongoing support and booster sessions can help maintain progress over time.